Cholesterol crystals are increasingly recognized as potent drivers of inflammation and atherosclerosis, serving not just as byproducts of lipid accumulation but as active triggers of cellular damage and immune activation. These rigid, needle-like structures form when free cholesterol accumulates beyond the lysosome's capacity to process and export it, particularly in macrophages engulfing oxidized LDL. Once formed, cholesterol crystals physically disrupt the lysosomal membrane, leading to the release of cathepsins and the activation of the NLRP3 inflammasome, a molecular complex that drives interleukin-1 set, IL-1 set secretion and amplifies vascular inflammation. Niacin offers a powerful countermeasure to this pathological cascade by intervening early, before crystals have the chance to form. At the core of niacin's protective effect is its ability to restore and accelerate cholesterol efflux from lysosomes. By enhancing the expression of CD38, niacin boosts the synthesis of nicotinic acid adenine dinucleotide phosphate, NAP, a signaling molecule that triggers calcium release from lysosomes through TRPML1 channels. This calcium release activates liver X receptor alpha, LXRA, which then upregulates Niemann-Pick C1, NPC1, a transporter that removes free cholesterol from lysosomes, as well as ABCA1 and ABCG1, which export cholesterol from the cell altogether. This cascade of events promotes the timely clearance of intracellular cholesterol, significantly reducing the substrate required for crystal formation. In effect, niacin acts as a cellular cholesterol drain, emptying the lysosomal compartment before free cholesterol can reach supersaturation and precipitate into harmful crystals. By doing so, niacin helps preserve lysosomal integrity, preventing membrane rupture, cathepsin leakage, and the subsequent activation of the NLRP3 inflammasome. Preventing inflammasome activation has downstream effects that are especially valuable in the context of chronic atherosclerosis. IL-1 set, a key product of NLRP3 activation, perpetuates vascular inflammation, recruits additional immune cells into plaques, and destabilizes the extracellular matrix through secondary cytokine cascades. Niacin, by blocking this pathway at its source, via improved cholesterol trafficking, helps reduce the chronic inflammation that accelerates plaque growth and increases rupture risk. What distinguishes niacin in this context is its ability to address the root biochemical imbalance that leads to inflammasome activation. While other anti-inflammatory therapies may target IL-1 set directly, as seen with monoclonal antibodies like canakinumab, niacin prevents the formation of cholesterol crystals that initiate the entire process. This upstream intervention is inherently more sustainable and may avoid some of the systemic immunosuppressive risks associated with downstream cytokine blockade. Furthermore, niacin's cholesterol-clearing effect appears to be independent of systemic lipid levels. In experimental models, its anti-inflammatory benefits persist even when plasma cholesterol remains unchanged. This suggests that niacin's action is fundamentally intracellular, targeting the dysfunctional lipid metabolism that characterizes foam cells and early atherogenesis. In summary, niacin represents a targeted strategy to prevent cholesterol crystal-induced lysosomal damage and NLRP3 inflammasome activation. By promoting cholesterol efflux at the lysosomal level, niacin not only protects cells from structural injury but also dampens the inflammatory signaling that propels atherosclerosis. Its ability to neutralize the physical and biochemical triggers of immune activation offers a compelling reason to consider niacin not just as a lipid modifier, but as a powerful anti-inflammatory agent in the fight against cardiovascular disease.